Hello class, welcome to Flourish Nursing Academy. I am Tutor Godwin. Below is a practical, evidence-based checklist of breastfeeding techniques that reduce the risk of common breastfeeding complications: nipple pain, trauma, engorgement, plugged ducts, mastitis, low milk supply, thrush, etc. Where useful, I give the reasoned rationale and brief pointers for when to seek help. 1. Start well. Early skin to skin and first latch. Put baby skin to skin and attempt first breastfeeds as soon as possible after birth, when baby is alert and stable. Rationale: early suckling stimulates milk production, helps establish latch and milk removal, and lowers risk of early problems. Supported by WHO, UNICEF, and Breastfeeding Society guidance. 2. Positioning and a deep latch, the single most important prevention step. Align baby's nose opposite the nipple. Support baby's whole body, tummy to tummy. Bring baby to the breast, not breast to baby. Wait for a wide open mouth. Aim so baby takes a large mouthful of areola, more areola visible above baby's top lip than below. Chin first, lower lip flanged out. Signs of a good latch: no ongoing pain after the first few seconds, rhythmic suck-swallow cycles, audible swallowing, rounded cheeks, not dimpling, nipple not squashed or excessively compressed. Rationale: deep latch prevents nipple trauma and inefficient removal, which leads to engorgement low supply. Endorsed by AAP, WHO, and IBCLC practice. 3. Feed on demand and ensure effective milk removal. Offer both breasts frequently, 8-12+ feeds per 24 hours in early weeks or on baby's cues. Avoid long scheduled gaps. Allow baby to finish the first breast. Baby releases or falls asleep before offering the second, or hand express, pump a little if you want to offer both. Rationale: frequent complete removal prevents engorgement and plugged ducts and supports supply. 4. Avoid unnecessary supplementation and restrictive bottles. Avoid routine formula or pacifier use in the first weeks unless medically indicated. If supplementation is necessary, use techniques that protect breastfeeding: finger SS syringe, supplemental nursing system, cup. Rationale: supplemental bottles and early formula can reduce suck practice and supply. Guidance from WHO, AAP. 5. Nipple care, prevention and early management. Preventative: ensure proper latch, air-dry nipples, and avoid harsh soaps. Use expressed breast milk or a small amount of purified lanolin if nipples are sore. Avoid persistent use of nipple creams if not needed. For existing trauma, reassess and correct latch urgently. Seek IBCLC. Short-term use of a nipple shield can sometimes protect damaged nipples while latch is corrected. Use under lactation. Guidance. Rationale: correcting latch is the key cure. Topical treatments relieve pain while healing occurs. 6. Prevent and manage engorgement and plugged ducts. Maintain frequent feeding expressing to avoid overfull breasts. Early treatment of fullness: warm compress and massage toward the nipple before feeding, and cool compress after for pain, swelling. Hand expression or gentle pumping to soften the areola may help latch. Avoid tight bras, clothing, and sleeping on the breasts. Vary feeding positions so all ducts drain. If a plugged duct appears, localized tender lump, more frequent milk removal from that area, warm compresses, massage toward the nipple during feeding, rest, and hydration. Rationale: stasis of milk contributes to duct blockage and mastitis. 7. Mastitis prevention and early action. Prevent by ensuring effective milk removal and treating plugged ducts promptly. Rest, frequent emptying, warm compresses and massage. Continue breastfeeding from the affected breast or pump to maintain drainage. Analgesics and NSAIDs reduce pain and inflammation. If symptoms are systemic, fever, flu-like symptoms, persistent red warm area, worsening despite home care, seek medical evaluation. Antibiotics may be needed. Rationale: continuing milk removal reduces risk of progression to abscess. Timely antibiotics shorten illness when bacterial infection is suspected. 8. Thrush, Candida, prevention. Avoid unnecessary maternal and infant antibiotics when possible. If yeast is suspected, burning nipple pain, shiny rash on areola, white patches in infant mouth that don't scrape off easily, evaluate and treat both mother and infant simultaneously per clinical guidance. Sterilize or replace pacifiers, tosh bottle parts, and ensure pump parts are cleaned. Rationale: treating both dyad members and cleaning equipment reduces recurrence. 9. Pumping and expressing technique. Use the correct flange size and comfortable suction levels for efficient drainage. Clean pump parts after each use. When expressing for supply or returning to work, mimic feeding rhythm. Frequent regular sessions and power pumping can stimulate supply when needed. Rationale: poor pump technique can cause nipple trauma, inadequate drainage, or oversupply if overused. 10. Maternal self-care and medication awareness. Rest and adequate caloric fluid intake support immune function and lactation. Smoking reduces supply and harms infant health. Review medications, including hormonal contraception, with a clinician. Combined estrogen pills may reduce milk supply in some women, so progestin-only methods are preferred early postpartum when possible. Rationale: maternal health influences milk supply and healing. 11. Special situations: inverted nipples, preterm infants, tongue tie, inverted flat nipples. Try breast stimulation, areola compression, and positioning that helps achieve a deep latch. Consider nipple shields or consult an IBCLC. Preterm infants: skin-to-skin, kangaroo care, expressed breast milk, and gradual transition to at-breast feeding under specialist guidance. Suspected tongue tie: evaluate if baby has persistent transfer problems despite good technique. Refer to lactation specialist and pediatrician for assessment. 12. Practical signposts. Red flags to seek expert help. Persistent nipple pain beyond the first minute of feeding, visible nipple damage or bleeding. Fever, 38 degrees C with breast pain redness that doesn't improve with initial home measures. Hard, hot, expanding area of breast, increasing systemic symptoms, or suspected abscess. Baby not back to birth weight by circa 2 weeks, or 4 to 6 wet diapers per day after day 4 to 5. Recurrent plugged ducts or mastitis. If in doubt, consult an IBCLC, lactation clinic, or your pediatrician or obstetric provider. Before you start, be comfortable and relaxed. Sit supported with pillows behind your back and under your arms. Keep baby skin to skin and undressed except for a diaper when possible. Remove tight clothing, bras, and make sure nothing presses on your breasts. Have a glass of water and a burp cloth nearby. Positioning: choose what feels best. Cradle hold: baby's head in crook of arm, body turned toward you, tummy to tummy. Cross cradle: opposite hand supports baby's neck, shoulders, good for newborns or latch help. Football clutch: baby tucked under your arm, helps after C-section or with large breasts. Side lying: lie on your side facing the baby for night feeds or if recovering. Step-by-step latch technique. 1. Support baby's whole body, not just the head. Align baby's nose opposite your nipple. 2. Encourage a wide-open mouth. Tickle baby's upper lip with the nipple or stroke the cheek to trigger rooting. 3. Wait for a big, wide mouth, lips flanged outward like a fish. 4. Bring baby quickly to the breast, chin touches first. Aim for the baby to take a large portion of the areola, more areola visible above the top lip than below. 5. Ensure the baby's chin and lower jaw are deep into the breast. The nose should be free for breathing. 6. If the latch is shallow or painful, insert a clean finger into the corner of the baby's mouth to break suction and try again. Signs of a good latch: baby's mouth wide and lips flanged outward. Chin touching the breast, nose free. Little areola visible above baby's top lip. No ongoing nipple pain after the first few seconds. Brief tugging at the start may occur. Slow, rhythmic suck-swallow cycles with audible swallows. Rounded cheeks, not dimpling. During the feed, let the baby feed until they release the breast or fall asleep. Offer the second breast if they are still hungry. Change positions occasionally so all areas of the breast drain. If breasts are very full and the baby can't latch, hand express or pump a small amount to soften the areola first. Common latch problems and quick fixes: shallow latch, pain after the first seconds, break suction with finger, reposition, and aim for a wider mouth and more areola in baby's mouth. Nipple pinching or blanched tip. Baby's lips may be folded in. Relatch with lips flanged out. Baby fusses but is not feeding. Try skin to skin, more awake timing, or a different position. Cross cradle helps control the head. Engorgement prevents latch. Apply a warm compress and gentle massage toward the nipple before feeding. Express a little to soften the areola. Use of nipple shields. Only short-term and with lactation support when needed. When to get help right away. Ongoing or severe nipple pain after trying relatching several times. Visible, cracked, bleeding, or blistered nipples. Baby is not having at least 4 to 6 wet diapers per day by day 5 or not regaining birth weight by 2 weeks. Fever, increasing breast redness, swelling, or a hard, hot, painful lump. Possible mastitis, a abscess. Recurrent problems despite following the steps above. Quick tips: bring baby to the breast, not breast to baby. Aim for a deep asymmetrical latch, more areola visible above baby's top lip. Fix the latch first. Creams and treatments help but won't cure a bad latch. Seek an IBCLC, International Board Certified Lactation Consultant, or local breastfeeding support if unsure or in pain.